we'll go into three case studies: the risk score calculation, modeling with mobile health data, and lastly will be the clinical trial eligibility modeling. And as you probably just heard, we are going to ensure that our session is recorded and we will distribute that later on. And we will end our session with time for questions and discussion. So we do have an exciting Train the Trainer bootcamp coming later this year. This is a 2-day virtual workshop that aims to empower attendees with the knowledge and skills necessary to become resource persons with their own institutions. And at the end of it, you will have an understanding of the researcher workbench, learn an overview of electronic health data and survey data, and you will also receive $300 in compensation for full attendance on both days. So to attend, you must be fully registered, a fully registered user by July 31st of this year, and be a registered user at any US-based institution that holds a DURA agreement with us. And you must submit this form by 5 p.m. Central Time on July 31st. Space is limited to 30 attendees, and all applicants will be notified of their admission status by August 25th. So if you have any questions about this Train the Trainer, please email our support team and they'll be able to answer those questions for you. That email is support@researchallofus.org. So as mentioned earlier, and some of you probably have just tested it out, as we go along, if you have any questions, please feel free to use the Q&A feature. We're going to be happy to answer those. The Q&A allows you to not only see your question and our answer, but also gives you the option of upping questions from others. And we will have time at the end of our session for Q&A. Okay, so let's go ahead and let's meet our presenters. Dr. Cathy Shyr received her PhD in biostatistics from Harvard University in 2022. Her doctoral research focused on developing statistical and machine learning methods for multi-study prediction and causal inference. Dr. Shyr's current research interests include characterizing clinical trial eligibility and the All of Us research program, and developing statistical machine learning methods to accelerate the diagnosis of rare diseases. And we also have Dr. Lina Sulieman. She is a research assistant professor of biomedical informatics at Vanderbilt University Medical Center, and her research focuses are applying temporal mining and machine learning to building prediction modeling to identify the patient's risks, and text mining using deep learning. She received her master's degree from medical informatics at the University of at Vanderbilt University, and a Bachelor of Science in Computer Engineering from Yarmouk University. Okay, so I'm going to go ahead and pass it on to Dr. Shyr and Sulieman.
Great, thank you so much, Ashley. I'll go ahead and share my screen. So during this event, we will learn about the All of Us research program at a very high level, starting with our mission, the specific data types, and the types of research that this data set can enable. After that, we'll dive into 3 specific use cases that leverage All of Us data to advance biomedical research. So to start things off, I'll give everyone a very brief overview of the All of Us research program. So, All of Us is an NIH initiative aimed at inviting 1 million or more individuals from across the US and its territories to participate in a longitudinal cohort study to advance precision medicine. And as of March 31st, 2025, we're really excited to share that over 848,000 individuals enroll in the program, of which 466,000 have completed initial steps, and over 633,000 have contributed data within the researcher Workbench, which is the cloud computing platform. So, at a very high level, our North Star, the program's mission is to accelerate health research to enable individualized prevention, treatment, and care for all individuals. And within this mission, we have three core pillars. The first is to nurture lasting relationships with the participants for decades to come, with one or more participants who have different backgrounds and come from different parts of the United States. And secondly, is to build and deliver one of the largest and richest biomedical data sets that is broadly available and secure for researchers like you. And last but not least, to catalyze an ecosystem of communities, researchers, funders who make this program an indispensable part of health research for many years to come. So like I mentioned before, we recently hit our major milestone of over 861,000 consenting participants. We have over 606 biosamples in the All of Us Research Programs database, and we also have over 470,000 electronic health records. So just to give everybody a idea of what types of research the program can support, we've got to list a couple of example studies and also modalities of research on the screen here. Now, this is by no means an exhaustive list, but I think from looking at these, we can get an idea of how really the wide breadth of different studies that this data can support. And these range from investigating associations between diseases, medications, genomics data, to performing early disease detection. Now, moving over to the right, we have, again, not an exhaustive list of the modalities of research that the program's data can support, but these range from artificial intelligence to machine learning to developing phenotyping algorithms to validation of other studies. Now, one thing I do want to point out is that the All of Us dataset is not a representative sample of the US. So without further statistical adjustment, that the interpretation, the findings from using the All of Us research program dataset may not be generalizable to the broader US population. The other point I want to highlight is that participants can decide to share or not share different types of data with the program. So All of Us is not a study with uniform follow-up of all variables. So to give everybody a better idea of the specific types of research that All of Us data can support, I've got a collage here of some of the really nice publications that have come out over the last 5 or so years. And these really span a wide range of studies from more clinical investigations looking at physical activity and how that relates to incident obesity across the spectrum genetic risk for obesity, and also something more methodological driven, for example, developing ensemble machine learning regression models for multi-ancestry polygenic risk prediction. Now, later in during the lunch and learn, we will actually be doing a deep dive into the study that you see here on the bottom left. This is a study that was published in Nature Medicine in 2022, looking at the association of physical activity, specifically step counts, over time and how that correlates with the risk of chronic disease in the All of Us research program. So before switching gears, I'd like to just quickly give everybody a highlight of the All of Us research program's timeline. So it's been exactly 10 years since the Precision Medicine Initiative was announced in the State of the Union address in January of 2015. And 3 years after that, in 2018, the program officially launched nationally with over 27,000 core participants. In 2020, which was about 5 years ago, that was the launch of the researcher Workbench, which Dr. Sulieman is going to talk more about in the next section. Again, this is our cloud computing platform. In 2022, this was the first release of 98,000 genomes from the All of Us researcher Workbench. And then the year after that was our second release with nearly 250,000 whole genome sequences. And of course, the number of samples and data types continue to grow as we move forward and onward from 2025. So the last thing I want to highlight is that if you are interested in really looking into the different types of research that all of us data can enable, I would recommend checking out the AOU Research Highlights, which showcases the latest and greatest research powered by all of us data and tools. All right, so with that, I will stop sharing my screen and hand it over to Lina, who will take us through all of us data and the researcher workbench.
Thank you so much, Kathy. Let me share my screen. We're gonna go into a deeper dive about the all of us, like what is the data, what do we have in the all of us? Like what data types do we have? How many of those data do we have? And we're gonna like provide a little bit description about the researcher workbench, which is the platform that researchers use in order to access the data and conduct some analysis. All right. So this is as of the latest CDR and you like or the latest curated data set that we have and provide in the all of us researcher workbench. This is kind of like the number of the participants who consented to share their their data. So we have more than 633,000 participants who responded to the surveys that the program sent them that collects information about various different kind of things, and we're going to talk about the different kind of surveys. More than 500,000 participants also provided some physical measurements, such as height, weight, BMI. We're also going to provide descriptions about those. More than 440,000 participants provided specimens in order, or like they consented to share their genomics data. So we have the genotyping arrays data for those participants. We have also more than 400,000 participants who also we have like their short read whole genome sequence data, and more than 390,000 participants who consented to share their EHR. So we have all their EHR data, not only for a specific phenotype, but for everything that is registered or that's basically documented in their electronic health record. And more than 97,000 participants we have we're providing their structure variant data. More than 59,000 participants who consented to share their wearable data or their Fitbit data. We have their Fitbit data that includes sleep, steps, and Kathy's gonna go through some of the she's gonna go through like some of the analysis that utilize the Fitbit data as well. And we have more 2,700 like log read data in the latest CDR or the data like the latest release data in the researcher workbench, as we call it, or we might call it V8. Now, if we want to look at the intersection between those different data types, because sometimes, yes, you might use one data type only, but also like you will have like more power in your study if you, for example, combine different data sets. And this is kind of like why we're calling this like the multi-omics, so that we can learn how to use those different data types in order to run the analysis. So for participants who have survey and genomes data, we have more than 414,000 participants. Now, if we want to look at the participants who have EHR or electronic health record, surveys, and genomics data, we have around 317,000 participants. If we want, for example, to look at the intersection between surveys, genomics, and Fitbit data, we have more than 41,000 participants. And for example, if we want to like look at 5 different types, genomics, survey, Fitbit data, EHR, and like the physical measurements, for example, we have like the number is gonna drop, but at least we have 28,000 participants, which is still a substantial number. I'm not going to go through all of them. I'm going to leave it up to you in order to read it so that we can have more time to get into the more fun stuff. Now, one of the things that we to highlight is like we are asking participants like to provide us some, as we call it, participant reported responses or answers via the survey. So we send our participant surveys and they fill it out. Now, one of the great advantages about this is that we're providing questions, or we're asking participants a question based on existing and validated methods or instruments. And those questions has been studied. We have been looking, like the team has been looking at those questions to make sure that it's easier to understand it from the participants' perspective. A lot of analysis went through in order to format them correctly, and those questions has been even translated. They're like, of course, we have them in English, but also they have been translated into Spanish. Now, we have around 8 different surveys. We have the basic surveys, lifestyle, overall health, and we're going to go through all of them. But the latest addition for our collection of survey is emotional health, history, and well-being, and behavioral health and personality. And those have been, I believe, launched in last year in 2024. And we started to get the responses for those that will be released as an off-cycle, meaning like we have the CDR8, but those responses are going to be released in the future as we call it an off-cycle. And we're going to go through like what each one of those have. Now, one of the major limitations about the survey, again, because we send those to the participants, we're relying on the participants to provide this information. So then we might have some recalling issues, meaning does the participants remember, or like, because we all have sometimes problem remembering, like, did we have this, or do I have this? So we're relying on the participants' recall to provide the answers, and sometimes the accuracy or the correctness of those questions might be a little bit affected by that. Some of the survey questions are being skipped, meaning some of the participants will skip this, whether because, oh, like, I really don't remember, so I'm going to skip, or because some of the participants who belong to a specific socioeconomic groups, they're not comfortable in sharing some of those answers. For example, like some of the missingness that one of the main surveys that we know we have a lot of missingness in is, I believe, in the basic survey, when we ask the participants about their income, the missingness rate can be between, I believe, 15% to 20%, which is a big number. So this might be like one of those. And when we did some imputation analysis, we noticed that some of the participants who are coming from low income are not willing to share this information. So this is one of the things that you really have to keep in mind. Now, let's talk about the most recent ones. And the reason why, there is something that I also forgot to mention, is that when we send out a survey to the participants, the survey process is not one time and done. The team is always working on, for example, creating more surveys and collecting more surveys. So it's an ongoing process. Now, one of the latest 2 surveys that we added to the collection of surveys that we have is the behavioral health and personality. This one includes around 35 questions that ask about, we don't ask usually about the participants, do you have an ADHD, or do you have psychosis? We ask you questions, for example, about like when you're having a task that requires a lot of thought, do you avoid or kind of delay getting into that? So we ask you questions about their behavior. Do they have difficulty concentrating on a specific tasks in hand? Are they having any problem remembering any appointments? So we're asking about those behavioral health that might help us indicate if the participants, for example, might be suffering from adult ADHD, which is like, again, it's a wide spectrum. Do they have like any panic disorder? And we have more than 95,000 participants who provided the responses for those surveys. When we look at the other new survey, which is the emotional health history and well-being survey, we also received the responses from more than 98,000 participants. So we asked the participants, for example, about have you been anxious recently? Have you been irritated recently? Do you have any problems do you have any things, or how often are you being bothered by different questions? Have you been bothered by being so restless? So we ask about their emotional history, health history, that will help us to understand if the participants is going through some lifetime anxiety, or if they have any present or past depression. again, those are those questions, they are correct to the time when we send out the participants to answer those surveys. It doesn't mean that they experienced that before or after, but within the time we collected the survey, we know more about the participant emotional health and well-being. All right. Now, in order to learn more about the different, for example, the different surveys, because I know some of the people who have, some of the researchers who want to work mainly on the survey or do analysis on the survey, they want to see the questions that has been asked. So you can go ahead and go to the Survey Explorer, which is a public website, or the surveys are public. So you can go ahead and see I want to see what are the questions that was asked in order to collect information about the patient's income or about the patient's restlessness. So you can go to the Survey Explorer and you will have access to both versions, the English and the Spanish version, in order to get the questions that were asked for our participants. If you want, for example, to know what are, or get for example, a count on, if you want, for example, to work on cardiovascular disease and you want to see how many of those participants, for example, have myocardial infarction, you can go also to the data browser and you can check how many participants have myocardial infarction, how many of those participants are on antihypertensive medications. And you can type it in the keyword search over here. I hope you can see my cursor, but you can type it over here and you can get the number of the participants rounded up to the nearest 20 buckets. So if the original number is 105 in the actual researcher Workbench, the number will be rounded up to 120 because this is a public data set and we're trying to protect the participants' privacy. We also, if you're interested in knowing about what people are working currently on the All of Us Workbench, on the All of Us data set, we have also a directory about the projects that all of us researchers are working on, because we asked all the participants, or all the researchers, sorry, to provide a small descriptions about what is their projects and what kind of hypothesis that we're working on and what they are expecting to find. So all those informations are public. You can use it in order, for example, if you're preparing for a grant or if you're preparing for just to know exactly what kind of analysis you're interested in, or does the All of Us data set have what you need, you can use those resources. All right. Any questions so far before we move on to the actual data types? Okay. So the first kind of data type that we want to talk about, or we'll be talking about, is the survey data. Again, as we mentioned, we have 7 main survey data. By the main, I mean those surveys have been, or at least 6 of those surveys have been launched or have been created since the beginning of the program. There has been some changes in those, but those 6 surveys, we asked, or we sent those surveys to the participants in order to fill them out. So we have the basic survey, which is around more than 500,000 participants, or in this case, 413,000 participants filled those out. Would include, we ask the participants, where do you work? What is your income? What is your education level? We ask also, we also send the lifestyle data for the participants to fill out, where we ask them, do you use alcohol? Or do you smoke? How many cigarettes do you smoke? If you quit smoking, at what age did you quit smoking? We ask them also about the use of recreational drug, or, for example, about their drinking habits. The third survey is the overall health, where we ask the participants about general health questions, or for example, about their daily activity. How many times do you work out? We ask about their overall health. Now, those 3 surveys, if the participants filled out those 3 surveys, which they are required in order to be included in the release data set, those are always will be filled by the participants. Yes, there are going to be some skips in some of those answers in each one of those 3 surveys, but all the participants should fill those 3 core main surveys. Now, we have also a survey about when we ask the participants about their personal and family medical history. And this is kind of we have around between 46 to maybe 55% of the participants who filled out, and my cat just made an appearance. So we asked the participants about their personal and family medical history. Where we asked the participants, we have, I think, we're covering more than 90 different phenotypes or diseases, where we asked the participants, in your family, have anyone been diagnosed, for example, with type 2 diabetes? Like we're asking like self, if the participants have been themselves been diagnosed with type 2 diabetes, and if any of their families have been diagnosed with type 2 diabetes. And we usually ask about the like sibling, daughter, son, grandparents, mother, and father, which can be really neat if you want, for example, to do some analysis that requires some family history. For example, one of the examples that jumps to my mind is a breast cancer, where you need to know the family history in order to assess the risk, the risk for those participants. Now, we have also the health access and utilization, where we ask the participants about how frequently they visit their healthcare provider. Are they visiting their healthcare provider? Like, when was the last time that they went to their healthcare provider? We also ask the participants about the socioeconomic factor survey. So we have, like, for example, we ask the participant about their neighborhood. Is their neighborhood walkable? Can they access the public transportation? We ask about their social life too. And we have also the COVID survey data, where we ask the participants about the impact of COVID-19 on the participants' mental health. And again, which was new or launched in 2024, both the emotional health and well-being and the behavioral health and personality. The second data type, which is like, I think a lot of people will be excited, like usually like get excited about, is the EHR, or electronic health record data. Now, we only include the participants because some of the participants did not consent to share the EHR. We include only the EHR for the participants who have been who consented to share their EHR. Now, we don't have access to that EHR. When the participants is recruited through an organization, we usually work with that EHR organization or that healthcare organization in order to get the participants record. So currently we're working with, like, I think with over 55 or 60 EHR sites in order to collect the EHR information for the participants who consented to share their EHR. Now, for each one of these sites, we have a script that maps it from the local EHR that converts from whatever the EHRs did, like from the data set, from the it capture or extract the data from that EHR site, and it convert it to a standardized format that we're going to talk about a little bit later. Then after that, we combine all this, like, for example, from those 55 sites, we combine all this EHR data from those different sites and put it in one centralized process. Now, because we want to protect the participants' privacy, we apply something called de-identification process, which is a method that is used in order to remove any information that can be used to identify or re-identify the participants. For example, we're scrubbing like their names, their like kind of like date of birth, any information that can be used in order to, along with other kind of pieces of information, in order to say, like, yeah, person 123 is John Smith from Arizona. We are trying to avoid that, and that's where we apply the de-identification algorithm. And like we get a lot of questions about, like, does all of us include the information for one data type or for one disease? The answer is no. We include, like, we have data or EHR data about everything. If the participants, for example, have an immunization record from 1980, we will have that reported or included in our data set. And as you can see over here, this is kind of like from a publication where we applied like some density analysis for the different kind of data that we have in the all of us data set. And that's why we see the number until 2020. Like you can see that there is like a lot of like different information, and the density of the information increased. We have information up to the time where the participant, when we extracted this information from the EHR. So if we want to repeat this, the latest number that you will be seeing is, I believe, like 2023 or 2024. So like every time we create or like we release a new data set, the most recent EHR information will be available for you to do any analysis or research on. All right, physical measurements, which is kind of the third different type that we have. So every time the participants enroll in our program, we ask them to provide, or they come to one of our enrollment centers in order to get their physical measurements. Those physical measurements include height and weight and body mass index, which can be calculated from the height and weight. We also take their blood pressure, systolic and diastolic, and heart rate. So those, you can say like, oh, like I can find those in the EHR. That's kind of like, that's correct. But one of the other things that we also try to collect is the waist circumference and hip circumference if the participants consented to provide those measurements, or like if the participants did not have any problem taking those measurements. And those measurements are rarely included in the EHR. I just wanted to like highlight that. We have also the wearable data or the Fitbit data. So far, we have only Fitbit data, and we're hoping that we're going to get the Apple Watch data for some of those participants. And we're collecting anything that is in the Fitbit data. We usually extract this information and provide it for the participants, including steps, heart rate, and sleep data. We also have the genomics data. All the genomics files have been processed, and all the QC part or all the QC steps have been applied, and so that you don't have to worry about spending a lot of your credits on preparing the data. The files has been prepared for you. All you have to do is just use whether Hail or a Plink in order to read the file, read the variants, and extract the information that you need in order to run your GWAS analysis or any genetic analysis that you want to do. Now, this is kind of a description of the pipeline, and the reason why we want to highlight that, because it will tell you exactly, or sometimes it will answer some of the questions that you have. For example, just what is the format of the data? If I see, if I know that this EHR site is using a different system than the other one, is the data going to be looking different? So we're going to go through what is happening. So again, we're collecting all of this. We collect the survey, we collect the EHR, we collect the Fitbit and the genomics. So we collect all those data, especially when we talk about the EHR, we collect all those data from those different EHR sites. Then the data goes through something called data harmonization, meaning we're trying to make sure that even if the data has different terminologies, even if the data is represented in something in a different way, we're trying to make sure that the data passes it through this process or the data harmonization in order to make sure that the data is being converted from a non-standard format into the standard format that we're looking for. For example, the EHR. Some of the sites will be using a system called Epic. Some of them will be using a system called Cerner. And those, even the data, how it's kind of formatted or represented in their EHR will be different. So what we do is we basically extract all this information, all this EHR data, digest it, and convert it into something called OMAP, Common Data Model, which is a standardized common data model that a lot of healthcare organizations who are doing research have that, in order to make sure if I am doing a research here and someone else is doing a research in Colombia, we both know if we're both using the OMAP common data model, we will be both using the same SQL query in order to extract the same exact information. The other thing that the data harmonization is going through is take, for example, from one data terminology or dictionary, and we're going to convert everything to the standard format. For example, some of the diagnosis codes that you will see, sometimes you will have ICD-9, sometimes you will have ICD-10, or sometimes it's SNOMED. What we all do, in the data harmonization, that we convert all those different data types and we convert them into SNOMED. And then we, in the next steps, we do some data refinement in order to make sure the genomics data, for example, participants, again, 1, 2, 3, they consented to share their EHR, they have the genomics data, and they have, for example, and they answered the survey. We want to make sure that the ID that will link all those details or all those data types is the same ID. So we'll apply data refinements in order to make sure that all the data is correct. We apply some data cleaning on the EHR to make sure the major outliers has been removed. And finally, we will provide this data in one centralized data set, or as we call a curated data repository, or if you if I slip and say CDR, this is the meaning of CDR, curated data repository. And we also provide data dictionary. So you can just like know like this table, this column, for example, person ID, this is the person ID identifier, or the zip3 in the person table. It will just like show you the zip code or the 3-digit zip code for the participants. So all those data dictionary is available for you as well in order to learn more about the data. Now, again, going back to the OMAP vocabulary standardization, again, for example, we have different data sources for the vocabulary. For example, we have ICD-9, ICD-10, even some of the PPI surveys. We all convert those into a standard common or like a standardized vocabulary, and based on the OMAP vocabulary, SNOMED is the standard vocabulary. So we convert all of those different diagnosis code into SNOMED. For example, for like the if we're using the EHR or the physical measurements or the PPI, all of those will be converted to line code and they will have that OMAP ID. Okay. So like this is also goes to also the procedures where like there's the CPT, there is line, we all standardize those into we standardize this into like the standard vocabulary. All right, now we're gonna talk about, sorry about that. Now, we're going to talk about the different access tiers that's available for you as a researcher. Now, the first tier that we have is the public tier. The public tier is just like it's available for everyone. So you don't need to register. You don't need to just like sign up for the All of Us program. This is available for everyone. But like one of the downsides of that one, it provides only a summary statistic or aggregate counts. So you're not going to be able to know exactly how many people. Again, we said like we rounded up to the nearest to 20 bucket. Again, I'm going to remind you, if, for example, if we have the number of the people on antihypertensive medications is 1,015, that number will be rounded to 1,020. This is kind of the first tier, so everyone without any login can have access to the summary statistics or the aggregate counts for the data types that they're interested in, or for a specific codes that they're interested in. The second tier is something called registered tier. This includes EHR, survey, physical measurements. Now, the dates have been shifted, and we're going to talk a little bit about that in the next slide. And we don't have genomics data in the registered tier. The third tier is something called control tier. So we have genomics data, we have the real dates, and eventually we're going to be releasing also some of the snippets from the clinical notes. And this is the second tier. And like if you sign up through your organization, most of the organization, you can have access to the control tier and the register tier. When you sign up, you might be asked to do an extra training in order to get access to the control tier. And the final tier, which is going to be available in the future, is where we're going to provide the individual biospecimens for the participants in order to perform like ancillary studies. And this is going to be in the future, not now. So we are working on that. Now, let's look at the difference between the register tier and the control tier, because some people will be kind of like interested in knowing what is the difference. So for the register tier, again, we have survey, healthcare, like EHR data, physical measurements, and wearable. Again, the dates in the EHR and like I believe also in the survey has been shifted. The shift is not a random shift. So some people who are like, for example, conducting longitudinal analysis will act like, well, this is going to be a little bit mess up my my data, or like it's going to mess up my analysis. Or will it mess up my analysis? The answer is no, because if we shift, for example, the diagnosis for like in the part, first of all, we do or apply the shift per participant's record. So the shift does not happen uniformly across all the participants. When we do the shift, we shift only for one participant's record. For example, again, going back to the participants 1, 2, 3, we're going to shift, for example, the participants, or we're going to shift all the entries in the participant's record by adding 70 days. For another participants, 4, 5, 6, we're going to shift the participant's record by shifting all the dates in that participant's record by subtracting 100 days. And all those shifts happen, I believe, whether we added or subtracted 365 days. So it's not going to affect any longitudinal analysis that you will be performing. And also, we removed some of the sensitive codes. For example, some of the specific gender, specific gender identity. And I believe all the participants who are above the age of 90 has been also removed from the registered tier in order to protect their privacy. When we talk about the control tier first, it will have genomics data. So it has like more data, especially if you want to perform any genomics analysis. And also the dates has not been shifted. So the real dates are provided for you as a researcher. And also more granular demographics. For example, like one of the examples that comes to mind, when you look at race, in the registered tier, you will have like white, Black or African American, Asian, multi-race, other, and skip. When you go to the control tier, you were trying to get the answers or like the participants' race, you will have like white, Black or African American, Asian, Middle Eastern or African American. You will also get like Native Hawaiian or Pacific Islander, others. So you will have more granular demographics data about the participants. And the registered tier, some of those have been combined in order to protect the participants' privacy, especially for especially when you try to use that like the registered tier. All right. Do we have any questions? Let me check the chat. Because we're going to start with the first case study. And if you have any questions, please let us know.
Lina, we can continue. We're running a little bit behind on time.
Okay.
So
all right.
Let's continue.
This one is going to be really quick. It's going to be a little bit quick. So the first case study that we're going to go through, again, we're not providing codes. Once you sign up to the All of Us dataset or the researcher workbench, you will have access to the actual code. One of the first case studies is how we're going to use the All of Us data in order to calculate the cardiovascular risk score. So cardiovascular disease affects like 1 in 5 adults in the US, or around 22% of the US population. And every 1 in 6 males will experience a cardiovascular disease incident, such as heart attack or stroke. And 1 in 7 females will also suffer from like a cardiovascular disease. Now, when we look at the risk factor for the cardiovascular disease, we have age, family history, and sex at birth. All those factors we really can't change. Like nobody can just like stop aging. We can't control our family history. Now, the factors that we can change that can be also considered as a risk factor for the for like cardiovascular disease is blood pressure, whether the participants have diabetes, BMI, diet, exercise, the cholesterol level, smoking, and stress. All like we can say like, oh, like you can control, like with diet and exercise, you can like the participants or the patients can keep their diabetes under control. But it's one of those factors that hopefully we're trying to change it through lifestyle, for example, and medication management. Now, the reason why we want to identify the risk score in order to identify the participants who are at high risk of being diagnosed with cardiovascular disease, and through educations and like changing the lifestyle, we can try to find a way in order to lower the risk for those participants. For example, if the blood pressure is high, we can work with the patient, or the healthcare provider can work with the patient in order to find ways in order to lower that blood pressure. Now, one of the major studies that has been working on the cardiovascular disease is the Framingham studies, which is a long-term research project that started, I believe in Boston Massachusetts in 1948. where the participants will go, provide some information about their like their smoking habits, whether they're anti-diabetic or not, or they have blood pressure. And those helped us identify the risk factor for the cardiovascular disease through like from that study. Now, this is kind of the calculation or the calculator that usually healthcare providers use in order to calculate the risk, where they would just like select if the if their patient is like male or female, their age, race, their current cholesterol, LDL and HDL, and you can see the rest. So they like after they put all the information, they calculate the baseline risk, and based on that, they can tell the patients where you are at high risk, and there are like a couple of things that we need to make sure to modify in order to reduce your risk. Okay. Now, all this data, like all those risk scores can be found in the EHR, like most of the times, except the smoking status. Usually the smoking status is buried in a clinical notes. Around like, there are like different studies showed that at least 43% of the between 43% and 70% of the smoking status is included in the clinical notes, which makes it really hard to extract. But in the all of us, we have it through the survey, as we discussed earlier. So what we try to do is try to calculate the cardiovascular risk score in the all of us data set. So the age, we have access to the age, race. Race, it's also, we use the one that the participants reported, not the race in the EHR. We also have access to the total cholesterol, so we extracted that. And so the first column tells us what parameter we are extracting from the all of us. What is used, kind of like, did we use the value or did we use like yes or no? For example, for the diabetes status, we only looked if the participants have diabetes, yes or no. This is kind of like the type of the of the factor. For example, diabetes status is a diagnosis. And if you're interested to know which OMAP table we used in order to extract this information, we included that in the last column. And the most important thing, like, we're gonna like use the smoking status, which is like we extracted this from the like lifestyle survey, and like usually you can find that in the observation table. All right. So when you go to the lifestyle survey, this is the question that you will see about smoking. So we asked the participants, have you ever smoked at least 100 cigarettes in your entire life? And if the answer is yes, like how frequently? Or like if they quit, for example, how old were you when you started smoking? And if they quit, we can ask like the participants, at what age did you quit smoking? Now, what we did is, giving from that question or the survey questions that we had, which is asked, have you smoked at least 100 cigarettes? We kind of defined that as our 0.0. As our 0.0. And from that point, and of course, this is the participants answered these questions after they enrolled in the program. I apologize for that. Okay. So from that point, we collected the measurements 6 months before and 6 months after they answered the survey. So for example, if they have like a blood pressure, systolic blood pressure measurements within 6 months, or like 4 months before they answer the questions, or 3 months after, both of those were included in our analysis. So we extracted like surveys, we extracted like a systolic blood pressure, total cholesterol, HDL, and whether the participants was prescribed any antihypertensive medications before, and whether they were prescribed aspirin. And for our outcome, we checked if the participants had any cardiovascular disease incidents, stroke, myocardial infarction. If they had it any in the upcoming years, then we label them as yes. Otherwise, we're going to label them as no. And we excluded all the participants who have a cardiovascular disease before they answer the questions, because if they already have it, kind of like it's not like this analysis is meant to identify new people who are trying to be who are at high risk of being diagnosed with cardiovascular disease. And we needed to exclude the participants who already have the CVD, because that will affect our analysis or bias our analysis. So using the values that have been used in the calculations, I'm not going to go through those, but feel free to do that. Feel free to like use them for your own calculations. Those are the coefficients that we used in order to calculate the risk score. So we collect the age, and for all those variables, we collected all those variables for those participants. We used the coefficients in order to calculate the risk score. Okay, so what do we have in the all of us? So we had around like 31,000 participants in the cohort, in the all of us cohort, who were included in our study, again, between the age of 40 to 79, who did not have any cardiovascular disease before they answered the smoking survey, the smoking question. Around like 64% of those participants, they self-report their sex at birth is female. And this is the race distribution. Around 58% of those participants were white, and the rest have like different races. They self-reported different races. For example, 21% self-reported that they were Black. And this is kind of the age distribution for our cohort. This also includes like the systolic blood pressure distribution. A lot of them have like their systolic blood pressure around like maybe around 120 to 130. This is the distribution of the cardiovascular score that we got. Now, a lot of the participants, since we have 58% of the participants were white, so you see like the kind of like the cardiovascular score, like the number of the white participants over here, like is the highest compared to the other participants races, and this is kind of the distribution of their ACV the ACV D risk score. It has the long tail. Now, when we compare the cardiovascular risk score to the US population, we notice that a lot of like in the all of us population, the lowest, like the risk score that is less than 0.25 is slightly lower than the US population, because we were trying to see like we're trying to benchmark the all of us against the all of us, like against the US population. Do we see the same trends or not? Do we see different trends? The majority of them have kind of like slightly similar risk scores, except when the risk score is lower than 2.5, where the US population had higher, had higher number within that category. The all of us had a higher risk score, had a higher risk score when we look at the risk score range between 10 and 14.9. When we look at the different kind of like race, when we basically like stratify based on race, and we compare that to the US population, the other participants have like risk score lower than 2.5. The majority of them kind of like the race kind of like slightly similar, but the two different categories that we see, there is a difference between the US population and the other ones is again the 10 to 14.9 and less than 0.5. But one of the things that we noticed, this is kind of like the US population, but one of the things that we noticed is that like African American or the participants who reported that they're Black, they have kind of like a higher number of participants who self-reported African American. They have a slightly higher risk of cardiovascular disease. All right, so from this, and I'm gonna hand it off to Cathy because we're behind. One of the the reason why the all of us research data set is really unique, because you're able to identify, you're able, for example, to run risk analysis that can be tricky to run, for example, in a regular EHR. Again, because, for example, if we take smoking status, for example, usually they're incomplete in the EHR, they're really hard to extract. You need NLP or natural language processing algorithm in order to extract it. And this can be scaled to other things. For example, the emotional or well-being that cannot be found in the EHR in a structured way. Or for example, the family history, we have it in a survey form. In the EHR, you have to run a natural language processing in order to extract that. So what we learned is that we can use, for example, the survey and the EHR in order to perform our analysis, as we saw in this example. And if you want, for example, to know or to rerun the analysis by, for example, going back in time, and see like, can I run the cardiovascular risk score for the participants before the enrollment, you can use the question about how old were you when you started like smoking, or if you quit, at what age did you quit, in order to see if the participants was a smoker in 1990, but they quit in 2000. So you can go back and look at like pinpoint the exact time that the participant started or was a smoker and what time did they quit.
Great. Thank you so much, Lina. So we're going to jump right back into case study B, looking at association between physical activity and disease risk. So as I mentioned before, this was a study that was published in 2022 looking at association of step counts over time with the risk of chronic disease in the All of Us research program. So I'll go ahead and share the link to this study with everyone in the chat so you can refer back to it if you're interested. Now, this study was led by two colleagues at Vanderbilt University Medical Center, Drs. Hyrel Master and Evan Britton. So before we really dive into the details of this study, I want to highlight the 30,000-foot vision for Fitbit data in the researcher Workbench. Now, one of the things that's very unique about Fitbit or wearable device data in general is really the richness and the depth of data that we have. And that has to do with the longitudinal follow-up and also the frequency at which these measurements are taken. So for Fitbit data, a lot of the measurements are taken daily, also minute level activity as well. So you can imagine the data is very high dimensional, very rich, and has great depth of coverage. And so because of this longitudinal follow-up, it really gives researchers the opportunity to investigate trends of device data over time. And once we combine it with other types of data that Lina mentions, for example, survey data, electronic health records, or even genomics data, that really opens up a lot of exciting opportunities to explore trends across different demographics, different disease conditions, and also different genetic types. So the overall motivation for this study is that physical activity has important health benefits. And really the underlying question here that the authors looked at is whether the exposure of walking more, so higher activity, whether that's associated with different types of health benefits, specifically with respect to lowering disease and mortality risk. Now, one of the gaps in the literature is that for the exposure, which is physical activity, it's typically assessed using self-reported measures, which is subject to bias over brief monitoring periods, so around about a week or so. And if we move over to the outcome, looking at the outcome, existing studies tend to look at a relatively narrow set of outcomes. So the authors saw an opportunity to really address and tackle this question by leveraging the data in the All of Us research program. So now for the exposure, instead of looking at self-reported activity measures that were measured over a short amount of time, Fitbit data is, again, incredibly rich, longitudinal follow-up across multiple individuals. And now moving over to the outcomes, the EHR data, as Lina mentioned, we're not looking at a specific or a subset of conditions. We're looking at all conditions. And so the EHR data can give a lot of opportunity for us to really investigate the spectrum of different human phenomes. So here's an overview of really the project plan for this paper. So the objective is that the authors wanted to look at the association between daily activity assessed using Fitbit and human disease, which is derived from the EHR data. So again, from the get-go, we see this linkage between two very large-scale data sets, the Fitbit data and the EHR data. The author's hypothesis is that lower activity was associated with incident chronic disease. And specifically for this study, they used data from the registered tier version 5, and they used three sources of data types. The first is Fitbit, looking at daily and intraday steps. The second is the participants' electronic health records. specifically their conditions from looking at their ICD codes, their laboratory values, and their medications. And last but not least, the last source of data type that they looked at was using surveys, so specifically sociodemographics from the basic survey. Now, I think one of the very important components that really contributed to the success of this work was the multidisciplinary collaboration across different types of personnel. So the primary investigator and co-investigator had a very rich background in clinical research, exercise biology, and physiology, and in collaboration with programmers and statisticians who were more well-versed in performing longitudinal data modeling and working on a cloud computing platform. It really brought a lot of synergy to the group. So to give everyone, again, a high-level overview of the data types that the researchers were dealing with, again, Fitbit data at that time in 2020 had about 60 billion cumulative steps. And this is a very large scale, high dimensional data set. And now moving over to looking at the outcomes, the researchers use EHR data, and there were at that time over 16,000 unique ICD-9, ICD-10 billing codes, which is a lot of information. And what the authors did was that they then distilled that information into 1,700, about 1,700 fee codes, which I'll talk a little bit more about in the next couple of slides. So the first thing that they did was that the authors built their cohort. And in the researcher workbench, one very straightforward and user-friendly way to build a cohort is to use the point-and-click cohort builder. So here's a screenshot of the tool on the bottom right. And essentially, if you haven't tried it out, this is a very user-friendly tool where you can specify the inclusion and exclusion criteria for this specific cohort. And so for this study, the authors first looked at which participants had Fitbit data in their cohort. And I'll talk a little bit more about how they define their cohort, but essentially what this cohort builder does is that it's going to take all of the inclusion and exclusion criteria that the researcher inputs, and on the back end, it will transform that into a SQL code query, which is then used to retrieve and fetch the data from the AOU database, and then you can use to analyze in the Jupyter Notebook. So let's dive into a little bit more details about the specific Fitbit cohort that the authors used in this paper. So they started by looking at individuals who had EHR data in the data set. And at that time, it was 214,000 individuals. From there, they then combined it with individuals who also have Fitbit data. So it's not perhaps not combined, but they really filtered it down to individuals who had both Fitbit and EHR data. And so that really narrowed down their cohort by quite a bit to about 6,489 individuals. And then further down, they then also refined the cohort a little bit more. So they only wanted to include individuals that had valid measurements or valid monitoring of Fitbit. And so they included individuals that had greater than or equal to 10 hours of Fitbit monitoring per day, and those who had greater than or equal to 100 steps per day. So from there, they then further narrowed it down to looking at individuals that had at least or equal, greater than or equal to 6 months of monitoring. So they really were interested in looking at the longitudinal follow-up of these participants. So with that, that brought us to a final cohort size of 6,042 individuals. So at a very conceptual level, what the authors did is that they had, starting with a very large, the original AOU data set, what they did is that they applied inclusion-exclusion criteria, which then helped them transform and wrangle the data into a smaller subset, which then they can export into the Jupyter Notebook to conduct their analysis. So one of the things I just want to quickly give everyone a sense of is the specific SQL query. And don't worry too much about this specific code. There is a specific workspace that you can look at and to replicate the analysis from this study, but this is really just to give you a high-level idea. So again, you might remember that one of the inclusion criteria for this study was that individuals needed to have greater than or equal to 10 hours or more of Fitbit monitoring per day. And so transforming that into the SQL code, what the authors did is that in their query, they selected individuals, their person ID, the date, and specifically they looked at where they had at least or greater than or equal to 10 hours of Fitbit data. And then they defined that as one of their compliance or inclusion criterion. So once they have that query, the next chunk of code is really setting up the path to really talk to the workspace bucket that the all of us data lives in. And the very last chunk of code is then running that query using this package in R called big R query. So I won't dive into the details. I'll point everybody to the specific workspace that has all of this information as we get further down the presentation. So here's a closer look of the Fitbit cohort. So as I mentioned before, this cohort included 6,042 individuals. This is a cohort that consists of majority white participants, females, and highly educated, with 71.4% of individuals having a college degree. Now, moving down to looking at some of the baseline conditions, about 2.8% of these participants had a coronary artery disease entry in their EHR, and about 23.7% had cancer indicated in their electronic health records. We also have a little bit more information about their smoker status and also use of alcohol. And then at the very bottom, we can see the median duration of follow-up for these individuals was just under 4 years. And on average, these participants took about 7,731 steps per day. So now we've spoken a little bit about the Fitbit data. Now I want to talk about how the authors wrangled and dealt with the electronic health records. Like I mentioned before, the electronic health records contains a very wide breadth of information across many different disease domains and types. So at that time, the registered tier had over 16,000 unique ICD-9, ICD-10 codes. So what the authors did is that they really distilled that information into over 1,700 fee codes. So fee codes, for those of you who are not familiar, is a high throughput method for defining clinically important and relevant phenotypes. So here's an example on the right-hand side where we have the ICD-9 code, the ICD-9 string, and the corresponding fee code and phenotype string. So here we see that the ICD-9, so there are unique ICD-9 codes for conditions such as cholera, cholera nonspecific, and what we can see that all of these different ICD-9 codes all map to the same exact fee code 008, which corresponds to intestinal infection. So essentially the fee code is being able to distill information from the ICD-9, ICD-10 codes. Another example is looking at typhoid fever, which has the ICD-9 code 002.0. And then if we also look at this other condition, other salmonella infections, which has a separate ICD-9 code, that both of these map to bacterial enteritis. So once the authors were able to generate the list of fee codes, then they linked both of the Fitbit data and also the fee codes to obtain their final data set. And here are the specific variables in their data set: average daily step count, age, race, sex, and whether or not they had one of each of these 1,711 fee codes. So for their exploratory analysis, the authors first performed multiple logistic regression models, adjusting for age, sex, and self-reported race to examine the association between average steps per day over an individual's entire monitoring period and all of the available fee codes. They calculated the odds ratios and 95% confidence intervals and reported per one step count increase. And disease associations that met the multiple testing adjustment, Bonferroni significance threshold, then and have a plausible biological link to physical activity were then further examined in downstream analysis. So here is figure 1 from the paper. We're going to take a closer look at it in just a little bit. And so basically what this plot shows us is that on the x-axis, we have the odds ratio. On the y-axis, we have essentially the log 10 p-value. So overall, this is really looking at the association between daily steps and the different chronic diseases across the entire phenome. So again, across the 1,711 phe codes. Now, each dot or data point that you see on this plot corresponds to a different phenotype or phe code. And everything that is labeled here, and they're color coded according to their level of statistical significance. Now, the horizontal red line here represents the Bonferroni significance threshold. So the higher the point lies, the higher the phenotype, it means that it's the more statistically significant the result is. The vertical axis that you see here, as odds ratio of 1 means that there is no association between step count and the corresponding phenotype. So what this tells us is that, for example, if we take a look at obstructive sleep apnea, and we look down here, it has odds ratio about a 0.88. So the interpretation here is that for every increase of 1,000 daily steps, the odds of having OSA decreases by 12%, assuming that all of the other variables are held constant. And so essentially what this tells us is that overall, as individuals take more steps, that this more activity level is associated with lower disease risk for specifically these diseases. And all of the gray dots that you see here towards the bottom are results that were not statistically significant. So let's take a closer look at, this is figure 1B from the paper, and this is looking again at the association between different chronic diseases and the odds ratio for step count. And this is looking at the specific effect sizes. And so essentially what this tells us is that type 2 diabetes has a very large effect size of about 0.7 or 0.69 in terms of odds ratio. Again, that means for every 1,000 step increase in step count, that's associated with about a 31% decrease in the incidence of type 2 diabetes. So after that analysis, looking again at the association between step count and disease risk, the authors also conducted another analysis, now really taking into account and harnessing the temporality of Fitbit data to perform time to event modeling. So what the authors did here is that they then examined specific significant disease associations from that first phase analysis, in addition to those that have plausible biological link to physical activity. And then they study them using separate continuous time-dependent Cox proportional hazards models. Participants were censored at their last medical encounter, which was defined as the latest measurement, lab data, procedure, or condition code. So this here is another major figure from the paper. And so let's go ahead and dive into these figures and take a look at the findings. So on the left-hand column, we have two charts looking at the adjusted hazard ratio on the y-axis versus the average daily steps in thousands on the x-axis. So the red line here that you see corresponds to the reference or the baseline group, which is defined as the median daily average steps of the entire cohort. So let's take a look at one of the data points on this plot to understand what this is telling us. So for example, if we look at 10,000 steps, again, on the x-axis, the units are in thousands. So if we look at 10,000 steps, the interpretation here is that in comparison with the median step count, the risk of obesity declined by 0.31 in terms of the adjusted hazard ratio when step count was increased to 10,000 per day. And similarly, we can also interpret the result from the sleep apnea. We can see that, again, in comparison to the median step count, the risk of sleep apnea declined about, I would say, maybe about 20-25% when step counts were increased to 10,000 per day. Now, moving over to the right-hand side column, on the right-hand side, we're looking at the cumulative incidence on the y-axis versus, again, the average daily steps on the x-axis. So what the authors did is that they stratified the analysis by looking at the cumulative rates of a new diagnosis for 3, 5, and 7 years. And so this really tells us how the risk changes when an average step count is maintained over time. To give everybody a better idea of what this is telling us, so we can also look at a specific data point. So for example, let's look at x-axis of 8,000 steps per day. So this is telling us that the risk of new obesity diagnosis at the 8,000 step count per day is 4%, 8%, and 13% at years 3, 5, and 7, respectively. So really the overall takeaway is that more physical activity was correlated with lower disease risks and cumulative incidence of diagnoses. So the authors also looked at a couple other conditions, including diabetes, essential hypertension, GERD, and major depressive disorder. So I won't go into the detail of each of those. If you're interested, please feel free to refer back to the paper. But the overall takeaway is the higher daily step counts are associated with reduced risk of diabetes, hypertension, GERD, major depressive disorder, obesity, and sleep apnea. Specifically, maintaining an average of between 8,000 and 9,000 daily steps showed protective benefits against some of these conditions. And more generally in this study, integrating large-scale Fitbit and EHR data can provide evidence-based guidance on activity levels to help reduce disease risk. And I think this is a great example of how data from the All of Us research program can support personalized recommendations for physical activity. So one thing I want to mention is that when it comes to handling large-scale, high-dimensional data like Fitbit and electronic health records on the researcher workbench, you have, as researchers, you have the option of scaling and changing the computational resources as needed. So you can change the number of CPUs, the RAM, etc. And the other thing is that on the researcher workbench, we also enable researchers to collaborate with other researchers. And so you can easily share your analysis code or workbench workspace with your collaborators. So if you're interested in learning more about Fitbit data, we have a really great featured workspace on how to work with wearable Fitbit device that you can check out on the researcher workbench. So with that, please feel free to put into the Q&A if you have any questions, and we will be transitioning to case study C, which is the last case study of the day. Last but not least, our case study C is characterizing clinical trial eligibility in the All of Us research program. So this was a study that was published in 2024. So the title of the study is on the screen in the Journal of American Medical Informatics Association, if you're interested in checking it out. So clinical trials, I think as many of us or all of us on this call can agree, are incredibly important to advancing health research. And clinical trials are the only way to conclusively establish the superiority of a treatment, and all other methods are subject to bias. Now, one of the really exciting things about the All of Us research program is that it has the potential to power a wide range of trials or randomized studies. And one great example of this is In 2022, the NIH awarded 170 million for a precision nutrition study. And this is really exciting because these advances will power this study, which is called Nutrition for Precision Health, to be one of the largest and richest precision nutrition data sets and studies to date. Now, as a part of this study are a number of randomized studies that will be conducted across multiple clinical centers across the nation. So, one of the very interesting and unique mechanisms that this nutrition study is a part of is called ancillary study. Now, ancillary studies are partner research initiatives that allow researchers to leverage the program's resources to drive discovery by collecting and adding new data to the All of Us data set. So, as Lina mentioned earlier, we have the different types here, the 6 different types of data that we currently provide on the researcher workbench. You can really think of ancillary study data as an addition to really enrich the existing data set. So in this case, the Nutrition for Precision Health, or the NPH study, is a specific study looking at how our bodies respond differently to food. And so they will be collecting a wide range of different data, including metabolomics, microbiome data that will be made available to researchers at a later time. This study is divided into 3 different phases, starting with the habitual diet study. And so this is essentially an embedded recruitment study where investigators of NPH recruited all of us participants to participate in NPH. Study phase 2 is a provided diet study with about 1,200 participants who have also completed module 1. And last but not least, the third phase or module is a live-in diet study that will recruit 150 module 1 participants. So the All of Us research program's potential to support a wide range of clinical studies like MPH has not been studied to date. And so opportunities for sponsors of future trial investment are also currently underexplored. So really illuminating and characterizing these opportunities in the landscape can return value to a number of stakeholders, including funders for future trial investment and ancillary study planning, participants through short-term engagement opportunities to participate in studies like MPH, and more generally, the broader community through long-term health discoveries. Excuse me. So the objective of this work is to develop a data-driven framework that categorizes high-level trial opportunities for both the All of Us participants and sponsors for trials across the government, academic, and industry sectors. So to characterize these high-level trial opportunities, what we did is that we leveraged 2 data sets. The first is the All of Us data set, specifically looking at the electronic health records. And what we did is that we looked at all of the existing conditions in the All of Us research program, and we mapped them to fee codes. So again, fee codes are an approach to group ICD codes into clinically meaningful phenotypes. Again, as a quick example, let's say if a participant has unspecified ptosis of the left eyelid and unspecified ptosis of the right eyelid, both of these ICD conditions will be mapped or rolled up to the same fecal condition, ptosis of the eyelid, which is more clinically meaningful for this analysis here. So what we did is that once we have these fee codes, we use the clinicaltrials.gov API. Clinicaltrials.gov is a comprehensive database on clinical trials that either has finished recruiting, currently recruiting in the United States and also around the world. And what we did is that we use these fee codes to query actively recruiting US-based trials, adult trials. And then for the matching, what we did is that for step 1, for every single All of Us participant in our data set, we extracted a list of the ICD codes from their electronic health records. So in this case, we have 2 participants, and there are 3 unique ICD codes here. We also extracted age, sex, as well as their location, which is their 3-digit zip code. In step 2, what we did is that we mapped each one of these ICD codes into Phi codes. So you can see that for participant 1, their abdominal pain, upper right quadrant, also left upper quadrant, were both mapped to the same Phi code condition, abdominal pain. And then we can remove any duplicates. And so our data set in this toy example has 2 participants with 2 unique Phi code conditions. Then the next step, what we did is that we took the list of unique Phi code conditions, and then for each condition, we queried ct.gov for relevant trials and retrieved information about these trials, specifically the age limit, the sex, and the site location, which was presented in terms of 5-digit zip codes. So once we have these 2 data sets, we can then combine them and merge them to match participants with trials based on very high level eligibility criteria. That's the condition, age, sex, and location. So again, in this toy example, we can see that participant 1, who has abdominal pain in their electronic health records, was matched with 2 unique clinical trials, whereas participant 2, who has cystic fibrosis in her electronic health records, was not matched with any recruiting trials at that time. So here's an overview of the trial opportunities across different demographic groups. So one thing I want to highlight is that the average number of match trials based on the analysis was about 58.4 per participant. And again, I want to caveat this by saying that we only looked at very high level eligibility criteria, so age, sex, condition, and location. So this number may be a little bit overestimating the actual number of trials if we were to take into account the very specific eligibility criteria. So one thing we can really look at from this 30,000-foot snapshot was the emphasis on mental disorder related trials, which you can see from this swimmer's plot. Another highlight that I want to point out is that we saw different opportunities across the different demographic groups. So for example, looking at cancer trials were a great opportunity among male participants. Conversely, we saw that there were a lot fewer trial opportunities outside of metropolitan areas, which could represent a potential barrier. So in addition to identifying opportunities for participants, we also looked at opportunities for future trial investment for sponsors. And this is a 3x3 grid that we call the Trial Opportunities Compass. And each panel in this grid represents a combination of few, some, many participants or matched trials. And so if we map on the specific NIH trials for the top AOU conditions, meaning the most common AOU conditions, what we can see is that, for example, that there are a lot of individuals who have essential hypertension in all of us, but at that time there were no match trials, which could represent a potential trial investment opportunity for researchers or study groups that are interested in essential hypertension. Now, moving on to the top middle panel, we see that we have a lot of individuals pretty well represented who have anxiety disorder, but at this time, at the time that this study was conducted, we saw a lot of match trials. So that represents an area where there was a lot of investment into the trial portfolio for anxiety disorder. So we also wanted to do a phenome-wide scan of different trial opportunities for participants. And what we did is that we specifically looked at conditions that were positively associated with a number of match trials in the All of Us research cohort. For the approach, we use negative binomial regression, adjusting for age, sex, geographic location, as well as the number of conditions in the participants' electronic health records. And so, because again, we're doing a phenome-wide association looking across thousands of different Phi codes, we conducted multiple testing adjustment using Bonferroni correction. On this slide, we have the PheWAS results looking across the entire All of Us participant cohort. So The x-axis is divided into different clinical domains, and they're colored differently as well. And each circle or each data point on this plot represents a different condition, and any data point that lies above the red line is statistically significant, also known as hits. So for legibility, we label the top 20 conditions here on the FEWAS. And so just at a glance, we really discovered that there was a wide range of hits across different clinical domains that reflects a variety of trial investment portfolios at that time. We also really there are different skyscrapers that really stand out on this Manhattan plot, specifically looking at this pink one, which showed us that there was an emphasis on trial investment for mental disorders. So just to dive into a little bit more about what these data points mean, for anxiety disorder was associated with a 47% increase in the number of matched trials, adjusting for other covariates such as age, sex, geographic location, et cetera, et cetera. And depression was the another condition that had a very large effect size, which was associated with a 42% adjusted increase, followed by asthma with a 40% increase in the number of matched trials. Now, we also looked at the relationship between the number of matched trials and different demographic and environmental factors. So this is, again, leveraging the electronic health records in all of us and combining that and linking that with the survey data information. So what we found is that participants from certain demographics had more clinical trial opportunities in the current landscape. Now, on the other hand, one thing I do want to mention is that, again, trial availability, which is what this study is really looking at, is not the same thing as trial accessibility. So even though we see that certain demographic groups or certain participants who have environmental stressors such as substandard housing quality, increased neighborhood discord, that trials may not be truly accessible to some of these communities due to a variety of different reasons, including under-design, access logistics, and lack of community engagement. But one signal that was very clear was, again, looking at the location where participants that were living in a non-metropolitan area were associated with having up to 13.1 times fewer trial opportunities in the current landscape. So here are really the key takeaways. The Phenome-wide association study enabled a discovery of a wide range of trial opportunities for all of us participants that reflects a variety of trial investment portfolios. Now, among the top 20 conditions that were labeled on that Manhattan plot with the strongest statistical associations, half were mental disorders, cancers, or respiratory conditions. Now, shifting over to opportunities for sponsors, the trial opportunities compass can be applied to combinations of different sponsors and medical conditions to help assess broad to specific scientific portfolios. And this tool can provide meaningful information to inform all of us ancillary study planning and policy making for trial sponsors. So based on our analysis of demographic factors and environmental factors, living in a non-metropolitan area was a major limiting factor that was associated with up to 13.1 times fewer matched trials for participants. And this really supports the conversation observation from qualitative studies that geographic location is a key barrier to trial participation. So I think this really lays the groundwork for more decentralized trials and more innovative technologies to reach participants in diverse areas. Last but not least, quantifying the magnitude of potential barriers by leveraging a large-scale health cohort, like all of us, can help provide guidance on prioritizing the most pressing barriers to trial participation. So to summarize, data from large-scale cohorts like AOU may inform trial portfolio planning. We looked at the specific potential trial opportunities for both the AOU participant population and sponsors. Again, the size and the richness of the All of Us data set really helped us illuminate trial opportunities across the entire phenome and all across different race and ethnicities. This highlighted a variety of trial investment portfolios, but also pointed us to some commonality and emphasis on specific trials in mental disorders, for mental disorders. This framework is, again, generalizable to other large-scale cohorts to support trial portfolio planning. Now, I also want to discuss some potential limitations and future work. This current study is a very high-level characterization of trial opportunities for adults, and we matched on very broad eligibility criteria. So in the future, we're definitely working towards incorporating more granular trial criteria and also extending this work to pediatric trials. As some of you may know that the program is preparing, it currently has already enrolled pediatric participants. And so, of course, the disease profiles can differ drastically between adult and pediatric participants. And so that really gives us an opportunity to explore different trial opportunities across the entire life spectrum. So last but not least, if you're interested in digging deeper into how this analysis was conducted, this work is available as a community workspace on the researcher workbench. So if you're interested, you can feel free to duplicate it and look at the analysis and also replicate it for your own interests.
So you will be receiving a short survey from us tomorrow on your thoughts on today's program. And we do greatly appreciate your feedback. Hearing your thoughts helps us to improve on future presentations that we have. So we do greatly appreciate that. And we do thank you all so very much for attending the presentation today. And we hope you all have a lovely rest of your day.